All right, so as I mentioned, this MRI scan shows a baby with a diaphragmatic hernia. Often on antenatal ultrasound, these children have polyhydramnios. They may have an intrathoracic gastric bubble, and when they look at the heart view, they may see peristaltic activity. And an MRI can sometimes be helpful just for further planning. And these women tend to be followed up regularly during pregnancy so that the delivery can be planned. Again, if it's a small hernia, it's not usually a huge problem at birth, but if it's a large hernia, then definitely they need to be born in a tertiary care centre with a neonatal intensive care unit, and I'll talk a bit more about that. We classify congenital diaphragmatic hernia by site. So there's the foramen of Bochdalek, which is 90% of congenital diaphragmatic hernias. This is a posterolateral foramen, usually on the left side, and they cause, obviously, respiratory problems, as I mentioned. 5% are foramen of Morgagni, which is anterior. They're much smaller and they tend not to cause as many respiratory problems. And then there's those through the esophageal hiatus, which tend to be very small and not cause any problems with the lungs. So you can see here, this is the diaphragm looking from above. You have the Morgagni hernias, which tend to be parasternal. You have the esophageal hiatus and the foramen of Morgagni, which Bochdalek, sorry, which is most commonly on the left, but can also be on the right. So, as I mentioned, it impairs normal lung development because for the lungs to grow, as you know, the baby has to swallow amniotic fluid and the lungs need to expand. And if there's something else in the chest, that can prevent the lung from growing. And that means these lungs are hypoplastic. So typically, again, on the side of the hernia, so on the left side. But it can cause mediastinal shift and affect the right lung as well. And the hypoplastic lung then results in fewer alveoli, fewer bronchi, abnormal pulmonary arterioles with increased musculature, which puts the child at risk of raised pulmonary vascular resistance and pulmonary hypertension. If there's enough mediastinal shift, it can cause an abnormal left ventricle development, and it can therefore impair the cardiovascular system as well. And this just shows a hypoplastic lung on this side. On this side with the heart hypoplastic, and the lungs. So presumably the hernia was on the left side. They often have other problems associated with the bowel, such as gut malrotation, congenital heart disease, separate to compression of the ventricle. They can also have some sort of ASD, VSD, tetralogy fallow, and so on. So they can also be get all the Vactor type things, although this isn't really part of the Vactal syndrome. And there is this thing called Cantrell's pentalogy with 5 things where they get diaphragmatic hernia, omphalocele, sternal cleft, heart outside the sternum, so-called ectopia cordis, and intracardiac defects. I've never seen that. I hope I never will. That's just one of the things you may see in a textbook. So hopefully it's diagnosed antenatally. If it isn't diagnosed antenatally, hopefully when the child has a chest x-ray for respiratory distress, we're able to diagnose it. And as you can see, this child has a large amount of bowel in its chest, causing mediastinal shift. And you would imagine that this lung would not have developed well at all. And mediastinal shift, there'll be some abnormal development of that right lung as well. So these children may present with respiratory distress, particularly if it's a very big hernia. They may be tachypneic. They may be cyanos, and part of that can be due to reversion to the fetal circulation due to pulmonary hypertension, and I'll talk about that in a subsequent slide. Typically, they talk about a scaphoid abdomen, which means the abdomen is instead of being distended and little babies have like little tummies that stick out, it's convex, and it's actually looks like the abdomen's almost empty because it's missing the bowel. and the heartbeats may not be where you expect them. So if they have mediastinal shift, the heartbeat may be heard on the wrong side, on the right side, as would be the case in this child. So when we listen to the chest, we may hear absent breath sounds on the affected side with a large hernia. We may hear bowel sounds in the chest. As I mentioned, a chest x-ray, if you do one at this stage, should be diagnostic. And if they have a really small hernia, they can present much later with feeding difficulties, and sometimes it just presents as an incidental finding. For example, the child comes in with some other thing, and they get a chest x-ray, and they notice the child has a diaphragmatic hernia. And I've seen a couple of children presenting at about 4 years of age where this has been the case. They can also recur, and the child may need subsequent surgery. One of the problems that can happen, and I had a case like this a few months ago, is that the diaphragm is so weak from where the hernia is, much like an abdominal wall hernia, although the development is obviously quite different. And so that even when the hernia is repaired, the diaphragm doesn't hold the bowel in the abdomen, and when the child lies down, it can push up into the chest. This is just another picture of a diaphragmatic hernia. Again, big, lot of bowel, heart moved to the side. This was a child we had in Ethiopia, and if you look carefully, you can see we were holding it up to the window, and you can see the building site outside. And then just a few more x-rays of some nasty diaphragmatic hernias. Again, typical appearance of bowel in the chest. So once we have the diagnosis antenatally, which, as I said on the previous slide, is in more than half the babies, we plan the delivery, and we want to deliver them in a tertiary care centre. And usually these babies can have a normal delivery unless there's an obstetric indication for a cesarean section, for two reasons. One, it's thought, as you know, that the normal delivery process does help squeeze all the water out of the lung and help the lungs. And if these lungs are a bit marginal, this may help. And two, because most of the time when they deteriorate, it's not right after birth. It's over several minutes when the fetal circulation reverts to the adult circulation. Most of these babies will require intubation at or around birth, and bag mask ventilation should be avoided, obviously, because there's concern that if the stomach's in the chest and we blow up the stomach, we're going to cause further lung compression and respiratory embarrassment. And then once intubated, these children may be okay on conventional ventilation. Often they need high-frequency oscillatory ventilation, and that's because the pressures generated can become too high to ventilate these children. So an oscillator, which, to be honest, I've never really understood how they work, but they basically, it almost shakes the air in and out of the lungs at a very high speed. We're talking respiratory rates of 80 to 100 to 200, and they get gas exchange this way. And in very severe cases, they may go on to ECMO to give the lungs a chance to improve somewhat before they can go back onto ventilation. So once they're intubated, a nasogastric tube should be provided to try and decompress the stomach as much as possible. When you have a lot of small intestine in the chest, then a nasogastric tube is probably not going to help that much, but at least it will help deflate the stomach and help any gastric juices or intestinal juices escape. So I was mentioning that these babies can get reversion to fetal circulation, and one of the reasons is that they get persistent pulmonary hypertension of the newborn. So if you remember from embryology and pediatrics, in utero the pulmonary vessels have a very high resistance, and the lungs are obviously full of fluid, not air. And so the blood doesn't really go through the pulmonary vessels. It goes via the patent ductus arteriosus, or through the ductus arteriosus, into the aorta and supplies the body that way. So when these kids are born, if they can't get a good breath and expand their lungs and reduce their pulmonary vascular resistance, then that high pulmonary blood pressure can remain. And additionally, the pulmonary arterioles are often abnormally thickened in these children, causing pathological raised pulmonary vascular tone. Add to that ongoing hypoxemia and hypercapnia because these children can't ventilate very well if they're really sick, and then that further increases pulmonary vascular resistance. So they get very high pulmonary resistance, and that can then cause shunting of blood from the right side to the left side through a foramen ovale, which at birth is usually going to still be patent, and it can also go from the ductus arteriosus into the aorta, and this will result in desaturation. And just to illustrate that, because sometimes it's hard to picture, so this is normal. Okay, the blood's coming to the right atrium, right ventricle, normal pulmonary artery, coming back from the lungs into the left atrium, left ventricle, aorta. So here we have really high pressure. So when the blood is coming back into the blood comes back into the left atrium, and that's still going to be oxygenated. But the problem is the right ventricle's got to pump so hard, and the right atrial pressure can rise, and you can get shunting of blood this way. Plus, if the pulmonary pressure is very high and it exceeds systemic pressure, you get flow into the aorta, and you can get systemic hypoxemia, and that's the main mechanism in these newborn babies. So, what is the pathology? Well, it's the abnormal pulmonary vasculature, as I said. And then also the hypoxemia, the hypercarbia, the acidosis. They can get a respiratory acidosis. And when they get really, really sick, they can get a metabolic acidosis. They also can get cold, and hypothermia further increases pulmonary vasoconstriction. And so all of these things, plus stress if the child's upset, can contribute to raised pulmonary vascular resistance, which just makes the child spiral further and further out of control. So if you can't oxygenate them because the pulmonary vessels are too constricted, then they're going to get more hypoxic, more hypercapnic. And if you can't ventilate them, you can't blow off the CO2, and then they can get a metabolic acidosis as well, and they can just spiral out of control. So really the management plan needs to be instituted in conjunction with the pediatric doctors and the obstetric doctors. And if the child has got a really large hernia, they pretty much need a slick intubation, get on the ventilator and get up to NICU, and then they can start other drugs, which I'll talk about in the next slide. But the aim is to avoid this reversion to fetal circulation, because obviously if we're hypoxic already from poor ventilation, and then the child then reverts to a fetal circulation and gets shunting, and it's just going to make it even worse, and they're going to get a metabolic acidosis on top of their respiratory acidosis. So to avoid pulmonary hypertension, all we can really do if we're ventilating these babies, and this includes when they're coming for surgery, is to avoid hypoxemia and hypercarbia. So we need to try and keep their oxygen level and their CO2 levels in the normal range. And sometimes we need to optimize the systemic vascular resistance by giving them ionotropes such as dopamine, because just a bit that will stop the shunting of the blood from the right side to the left side, and that can help also improve the pulmonary blood flow, and the more blood flow through the pulmonary circulation, the better the oxygenation. So, like a lot of these neonatal conditions, repairing the hernia isn't really going to change any of this pathology, and therefore the emergency is physiological. So it's not a surgical emergency. So we do not need to operate on these children straight away. The lung is malformed. It's congenitally abnormal, and nothing we do is going to change that in the early period. The thinking is that in newborns, they do still have some plasticity in their lungs, so they can still develop some alveoli and some bronchi over time if you fix things early enough. And so that's why we do try and fix them sooner rather than later, but that doesn't mean they need to be done straight after birth. So usually they try and optimize them, ventilate them for a little while if they need that, and then fix it at 72 hours. If they're coming not intubated, then that's usually a good sign that the child isn't that sick, and hopefully will have a good prognosis. So what do they do in that time in NICU? Well, they try and improve their respiratory function. Ideally, we want these children on less than 50% oxygen before they come to the operating room. And definitely we don't want them on the oscillator, because obviously we can't oscillate on our machines, and that means they're pretty marginal. So sometimes these children will improve with a few days of ventilation, give the pulmonary vessels a chance to open up a little bit, and with treatment with ventilation to try and get the CO2 down, the oxygen up, it helps reduce the pulmonary vascular resistance. If we can correct the acidosis and also give nitric oxide, and this is one use for nitric oxides, which is a good pulmonary vasodilator, we can sometimes get these children into a better physiological state to come to surgery to get their operation. So the ways, again, to recap, what we can reduce pulmonary vascular resistance really are to ventilate, get good oxygenation, try and get good ventilation to get rid of CO2, try and keep the child warm, and give drugs like nitric oxide, and if need be, some inotropes. Although ideally we'd want the child off the inotropes by the time they come to the operating room, because if we're still needing to support their systemic vascular resistance to prevent shunting of blood from the right to the left side, that would suggest that their pulmonary pressures are still a little bit too high. The other thing we need to do once we've assessed their respiratory function and their gas exchange and their acid-base balance is just make sure they don't have any other major associated conditions, particularly cardiac defects, which might change our anesthetic plan a little bit. And very rarely these babies will be done in the NICU if they're too sick to come to the operating theatre, and via an exit procedure. An exit procedure is basically where the baby is intubated at birth, so that the head comes out, the anaesthetist intubates the baby, or the paediatrician intubates the baby while the baby is still getting blood flow from the cord, so that there is still a little bit of time to intubate, and then the child can be ventilated straight away, or even put on ECMO pretty much straight after birth. These are done infrequently. I think in Toronto, when I worked there, they might have done a couple of these a year. It's certainly only done for something that is very severe, so it would be a very bad hernia. Other times they do exit procedures for kids, for example, who were born without a larynx, and they do a tracheostomy at birth, or something that would be fatal if the child isn't ventilated straight away at birth. So if you get one of these children, if they're already intubated, it makes your job a little bit easier. Your main job then before they get to the operating room is to set up your ventilator. So I usually try and copy whatever respiratory settings they're on in the NICU. Generally, I find in the NICU they run much smaller tidal volumes than we do. They're running like 3 to 4 mils per kilo versus our 7, and they have rates around 60. Obviously, in these babies, I look carefully at the pressures and the volumes. It may be appropriate to have really small tidal volumes in these babies, because if they have really stiff, restricted lungs, that is appropriate. But if they have better lungs, I usually tend to run them closer to 6 to 7 and reduce the respiratory rate, because I don't know that our ventilators are sophisticated enough, and our circuit tubing may be a lot longer than the NICU. So I don't know, I've never felt comfortable with the respiratory rates of 60 on our ventilators, but I'm sure it's doable. So when we induce them, though, if they're not intubated, then I would generally do an inhalational induction. If they are intubated, then you can just give them a big slug of fentanyl, paralyze them, and away you go. Generally, if they don't have a nasogastric tube in, I would put one in and decompress the stomach prior to induction, much as I would do for a pyloric stenosis. And then either inhalational induction or rapid sequence if you're feeling particularly brave, to avoid mass ventilation, again because of the risk of gastric inflation. I have to say that in neonates, maybe I'm just a bit nervous, but in neonates, I tend to breathe them down on gas and keep them spontaneously breathing for as long as I can. Although they can go apneic, obviously, from gas, but I'd rather do that in this situation than a rapid sequence. Mainly because my concern is I won't get a good pre-oxygenation. They'll desaturate like a stone, and then it can all become a bit stressful. But the books will say rapid sequence as well. So muscle relaxation is essential in these babies. If you've ever anesthetized a really small baby, you find that if, first of all, just take away the congenital diaphragmatic hernia for a second, if the paralysis wears off and they fight you, even the slightest little bit, it can be really hard to ventilate them. If you think that you have a 3 kilo or 2.5 kilo baby and you're talking about tidal volumes of 15 mils, even if their diaphragmatic resistance, because they're not paralyzed and they're fighting you, especially in these kids, because their CO2 will be a bit higher, so there's no chance of hyperventilating them to make them apneic. If they lose 5 mils of their tidal volume, that's like a third of their tidal volume that you're going to lose from them not being paralyzed. I learned that the hard way when I was a fellow. NICU never paralyzed their babies, and I was doing a transfer from NICU, and I was going to paralyze. They said, "Oh, no, we don't do that." I didn't paralyze, and the kid was sitting in the 70s by the time I got to the operating room because I just couldn't ventilate them with them trying to fight me. So my approach now is to paralyze them all. It doesn't matter what muscle relaxant you use. Something long acting is fine because you're not going to be extubating them at the end of the case for the most part, except for the ones that are very well and presenting later, where 4 or 5 years old. But for the most part, you're not extubating, so you can use pancuronium, rocuronium, becuronium, atracurium. It doesn't matter. But you want that out of the picture, so it's that the stiff lungs or the difficulty ventilating is not from muscle relaxation or the diaphragm being a problem. And then you try and ventilate them the best you can. Try not to exceed 20 centimeters of water to avoid barotrauma. I mean, sometimes you might have to go up to 25, but generally you want to employ a protective ventilation strategy like we discussed for one lung ventilation, same sort of idea. Monitoring, end-tidal CO2 is really, really helpful. If they're really small, as you guys know, you don't always get a very accurate end-tidal CO2, but it still can be helpful. And it tells you, A, that you're ventilating, B, that you have cardiac output, which is important if the child is really sick, and C, it does give you some idea of the effectiveness of your ventilation. If the end-tidal CO2 is continuing to rise, that gives you some idea that you're not winning with your ventilation. Arterial line is very useful. They can be hard to put in at this age, but fortunately a lot of these babies coming from NICU have umbilical arterial lines, so you can do gases, and I think the gases can be very helpful, again, to guide your ventilation. I usually like to get a gas in these babies early so I can see what my end-tidal arterial gradient is, because if I know, for example, that because I have a lot of anatomical and equipment dead space in these little ones, I know that if my end-tidal is 10 to 15 above my arterial, then that gives me a guide of where to aim my ventilation and to try and keep my arterial CO2 around 30 to 35 if I can. Some sort of central access for inotropic support is useful in the really sick ones. Again, they may have an umbilical venous line, and they may have or a long line put in by the neonatologists. Temperature probe is essential. Newborns, high risk of heat loss. I've already mentioned hypothermia can increase your pulmonary vascular resistance, and this is one thing that is preventable. So really, we don't want to add that to all the other problems that potentially can occur. Dia has asked if we should use pressure control or volume control mode. I always use pressure control in children, and I do that for two reasons. One, because I always think a lot of our ventilators, especially if you work in hospitals where you do adults as well as children, which we all do, often the ventilator's setting is defaulting to 500 mils. And so if you forget to change that, you're putting potentially 500 mils into a little baby. And obviously that's very dangerous. So for that reason, I always use pressure control, so that at least if it's set at 20/5, you're not going to, you might put a slightly too big tidal volume, but it's not going to be 50-fold what you should be putting in. The second reason is when you look at a pressure over time curve versus volume over time curve, when you ventilate someone with volume control, you essentially say you set the volume at 50 mils for a 10 kilo baby or a 7 kilo baby. You're essentially putting that volume in, and the peak pressure can be quite high because it starts blasting 500 mils of volume in, and it reaches the peak pressure, whatever you set your maximum pressure at, or below that. And then the pressure then falls away as the volume continues to go in. Whereas with pressure control, you say you set it at 20 centimeters of water, it opens the lung to that 20 centimeters of water and holds it at 20 centimeters of water for the duration of your inspiratory time. So you get a nice big square wave versus a wave that's curved. And if you look on your machines with spirometry, you see that. So in theory, you have slightly more volume under your pressure versus time because it's a square wave versus a curved wave. So you should get slightly more bang for your buck. So that's why I favor pressure control. And you might have seen that if you're ventilating someone with laparoscopic surgery and you're struggling, your pressures are really getting really high on volume control, and you switch them to pressure control, you might find you get more volume in for the same pressure, and so it's a little bit more effective, and that's why, because of the way that it works by holding that higher pressure for the duration of the inspiratory cycle. So in these children, as I would do in any adult with restrictive lung disease, I want to get as much volume in as I can for my pressure to try and help blow off CO2. So I would definitely use pressure control. So the best predictors of survival in these kids are the PaCO2 and the respiratory index. So the PaCO2 is obvious. If the PaCO2 is controlled, then it means that we can ventilate them, and that's a good sign. And the respiratory index is the product of the mean airway pressure and the respiratory rate. So if they have normal CO2s and are not too difficult to ventilate, they have a good prognosis. If the CO2 is very high, or they need a high rate and they have high pressures, then that's a very bad prognostic sign for these kids, which is a no-brainer. So just recapping, when you go off to sleep, doesn't matter whether you gas them down or do an IV induction, but as I said, I personally would breathe them down. And then I maintain them with a little bit of gas and a lot of opioid and a lot of muscle relaxant. I don't use nitrous oxide because I'm concerned about hyperinflating that bowel, because, as you know, nitrous oxide diffuses into bowel, and you could compress the lung more until the surgeons have fixed that problem. Aim to keep the airway pressures below 20, low tidal volumes, high respiratory rates. PEEP may be helpful, and aim to keep the PaCO2 under 35 and PO2 above 80, and that's to help with your pulmonary vascular resistance. Pulmonary mechanics can change a lot during the case. Dia's asking about low MAC. I tend to not give them a lot of volatile, like maybe half a MAC or something like that. Amnesia is not a big issue. You got to keep them still, which I'm going to do because they're paralyzed. I'm going to give them something for pain. I'll give them a little bit of isoflurane, but I don't want to drop the systemic vascular resistance too much, because then I worry about right to left shunting. So, the only ones of these I've done haven't ever been that sick. I've been kind of lucky. The ones that have been really sick haven't made it to the operating room. I think we had one when I was in Raphidia that they were going to bring down, and the child died before they got to the operating room. Yeah, Dia, you have another question?
Yes, sir. I would like to ask. Yes.
I'm not hearing you very well. Can you type it, maybe? Okay. So the pulmonary mechanics can change a lot during the case, particularly if the surgeons are pushing lungs and the chest. And it's really important that once the hernia has been reduced, not to recruit the hyperplastic lung, because it's not a collapsed lung, it's a hyperplastic lung. So it's not like when you're doing one lung ventilation or something like that where the lung has just been collapsed. This lung will not come up. So if you try and recruit it, you can cause a pneumothorax because some of these alveoli may not be normally developed. So that's really important to remember that, because sometimes the surgeons forget and they ask you to bring the lung up, and you can't. I should make the point that sometimes they do these laparoscopically or thoracoscopically in the slightly bigger children, and that's great if they can do it that way. If you're aiming to extubate, because then the child will have a lot less pain and much smaller cuts. If it was a sick newborn, though, I would strongly fight with the surgeon trying to do it thoracoscopically or laparoscopically, because they have to insufflate air, often CO2, to retract the lung when you're doing it thoracoscopically, and you're having enough pressure, problems with pressure as it is, and if they go and inflate the stomach to do it laparoscopically, that's going to make your life a lot more difficult. They usually, they often do a combination of a thoracoscopic and an abdominal approach, and I have to confess, I'm never sure which way they're going. And I've seen them do both, but most commonly it's an abdominal approach. Everything down and fix the diaphragm. Often ventilation is worse after the hernia has been reduced, because now you have abdominal pressure increased. And similar to what we were talking about with omphalocele, it's possible that the abdomen is not being stretched up as it should be, because the bowel hasn't been there. And so that might then put a bit of pressure on the diaphragm and the lungs and make ventilation difficult until the abdomen stretches up. So post-op, they go to NICU, paralyzed and sedated and ventilated. Complications are quite high. They can get pulmonary hypertensive crises within the first 12 hours. And mortality rates vary widely, but as you can see, they can be quite high. I would give them PEEP. Dia's asked what about PEEP. I would give them PEEP. The only reason I might back off on the PEEP is if I was really struggling to ventilate them. PEEP is going to help your oxygenation, but if you're really struggling to clear CO2, you might want to back off on the PEEP to try and increase your volume. PEEP should help with your tidal volumes, but sometimes you have to play with it to see what happens, because obviously if you have 5 of PEEP, that only gives you 15 of inspiratory pressure, and if you need to go up on that, then you might have to come down a bit on the PEEP. So I sometimes, in the kids with sick lungs, I play with PEEP, I play with rate, and I play with the IE ratio. Sometimes I give these kids, instead of a 1:2 IE ratio, I give them a 1:1, or sometimes even an inverted IE ratio. Because if you increase your inspiratory time, you're giving more time for more volume to get in there for the same pressure. So if you've got the rate of 30, and you have an IE ratio of 1:2, that means in 2 seconds, only a third of that time's for inspiration. If you make it 1:1, then you have a longer inspiration. You can get more air in and better ventilation. But obviously, it doesn't have as much time to leave, and so that's not a good thing in kids with gas trapping and asthma and so on. But in these kids, the main problem is stiff lungs. So sometimes you have to try that. So some of these kids do end up on ECMO, and there's not a lot of data, but it does not seem to improve survival. So if you're on ECMO, your number's up. And I think that says more about the pathology of these patients. If they're severe enough to end up on ECMO early, it means that perhaps their lung development was so poor that we just can't ventilate them, and that generally doesn't bode well for their future survival. There's a few experimental therapies around. One is doing a tracheal occlusion in the second trimester, this is in utero, causing retention of lung fluid and increasing lung growth, because the lungs, the amniotic fluid that they swallow and inhale helps with the lung growth. The thinking is that if we can occlude the trachea irreversibly, it will help nourish the lungs and improve the lung growth. And there's also perflubron-induced lung growth. So perflubrons are these oxygen-carrying fluids that exist, and filling the lungs with perflubron to stimulate lung growth in children with congenital diaphragmatic hernia or ECMO is being looked at. I believe this one's the University of Michigan, actually. They're doing studies, I assume, on animals. But given that ECMO, they're probably not going to live anyway, they might be able to enroll some of these children into a trial to see if they can help them. So that's congenital diaphragmatic hernia. As I said, a lot of these kids are sick, but a lot of them aren't, and I've been fortunate that most of the ones I've done haven't been that terrible, and at least we've got them back to the NICU in decent shape. So are there any questions on that? Because then I'll move on to tracheoesophageal fistula, which isn't as complicated a topic. It's a little more straightforward.
Yeah, I had a question about PEEP.
Yeah. Yeah, go ahead. Sorry, you're saying Dear had a question. Yeah, no, I answered that question about PEEP. I mean, I was saying I would give them PEEP, but I may wind it down. Okay. So tracheoesophageal fistula is where there is a connection between the trachea and the esophagus at birth, and sometimes there's no actual fistula. There's just esophageal atresia, but that falls into one of the categories. So there's different types. They can be classified A to F, or they can be classified by the way they look. The most common is esophageal atresia, which is this, with distal fistula, and this is the called the H type. Actually, it's not called the H type. This is the H type. This is the second, I think the second most common. Yeah. So this one is esophageal atresia, which it counts as tracheoesophageal fistula pathology, but it doesn't count as one of the types of fistula because there's no connection. So the H type would then be the next most common, but this is by far and away the most common. So esophageal atresia, with distal fistula, meaning that there is a fistula distal to the atresia, as opposed to up here where you have a proximal and distal fistula. So this is the most common, and it also tends to be sort of a triphasic problem in a lot of kids. So they come in at birth, they get the fistula ligated, the esophagus reanastomosed. These kids then come back when they're sort of toddler age group, between the ages of 3 and 6, with swallowing problems and esophageal strictures for dilation, and then they can come back even later with motility disorders. So, but I'm told that's only a minority, and some of them do quite well. So 1 in 3 to 4,000. So again, reasonably common. A lot of the time, now this is part of the vactual abnormalities. So remember we talked about some of the vactual stuff before, but there are associated other congenital abnormalities in 40%. So they can have diaphragmatic hernia, duodenal atresia, imperforate anus. There is an association with chromosomal abnormalities. They can get the kidney and urinary tract problems with vactual stuff. Most commonly, they get cardiac associated abnormalities, VSD, ASD, tetralogy of Fallot, PDA. They can get musculoskeletal, so limb deformities and vertebral deformities. And this is just a revision of what vactual stands for. So vertebral, anorectal, cardiac, tracheoe-sophageal fistula, esophageal atresia, and renal and limb issues. So these babies are often diagnosed antenatally due to polyhydramnios, and they may detect the other abnormalities at the same time. If they don't get picked up antenatally, they're often diagnosed soon after birth, particularly if there's esophageal atresia. So just going back, the type that can be missed is the H type, because these kids can swallow okay and they're going to breathe okay, but they're going to get coughing every time they feed, and they, sometimes they might turn blue, or they might, if it's a really small fistula, they might just turn up with chest infections, recurrent chest infections. And sometimes they present quite late, like 3, 4, 5 years of age, with recurrent chest infections. They can get diagnosed with asthma. I had a child who was about 8 years old, 9 years old, who had a tracheoesophageal fistula repaired at birth, and for some reason must have been lost to follow-up, but was diagnosed with asthma, kept getting chest infections. And eventually he saw a pediatrician who was astute enough to put 2 and 2 together, and I think it was actually a cardiologist, a pediatric cardiologist, and refer him for a barium studies, and that showed that he had a tracheoesophageal fistula that had recurred. So these children can get missed and present late. So if they have the most common type, though, they can't swallow, so they're often drowning in their own secretions. The classic thing is pooling secretions, because they can't swallow their saliva, and it pools in the esophageal pouch. And then people would put a nasogastric tube down and take a chest x-ray, and it should show the nasogastric tube is just curling up in the esophageal pouch. So if they haven't done that, then the child may present with coughing or choking when feeding, respiratory distress due to excessive secretions. They can have vomiting, cyanosis, and often a lot of saliva in their mouth. And they can get a very distended abdomen, round, full abdomen. So, as I mentioned, they can present late with recurrent chest infections. They may present with their associated abnormalities. So, this is just a chest x-ray showing a nasogastric tube that is stuck here. So essentially curling up in the esophagus. There is something called a repogal tube, REPOGLE, which is a special tube that allows you to continuously suck the secretions away, and that's usually what these children get. So the chest X-ray, classically, if you have a nasogastric tube, you'll see it curling up. Otherwise, you'll just see air in the upper pouch. And in the abdomen, you'll see absence of bowel gas if it's type C and type D. So I'm just going to go back to show you which ones we're talking about. Yeah. So if it's one of these, there may be reduced bowel gas, but they can still get bowel gas through here. But it's most of the bowel gas we swallow. So these kids won't have any bowel gas, or not a lot of bowel gas, unless we of course ventilate them, and in this type as well. So there will be an absence of bowel gas on the X-ray, and here you can see there's not any bowel gas. Sometimes these kids have associated duodenal atresia, which is supposed to be quite rare. And the problem with when they have a duodenal atresia as well is it's kind of stressful, because if you're putting one of these kids to sleep and they have a tracheoe-sophageal fistula and you ventilate them, you can blow up the fistula and blow up the stomach, and what that does then is expand the stomach, push up on the lungs, and make it harder to ventilate them. And if they have a normal duodenum, then this bowel gas eventually goes out that way, because obviously you can't suck it out because they don't have an esophagus. But if they have a duodenal atresia, then they get the classic double bubble, but the gas has got nowhere to go, so it can be quite stressful during the induction. And I'll talk about what we can do to try and mitigate this. So again, pre-op workup, familiar theme to what we've talked about with the other kids. Any kid with a congenital abnormality, you have to see what else they've got, and you have to particularly look at heart, obviously look at lungs. If the kid's presenting at day 10, 12 of life, maybe they've already had a couple of chest infections, maybe they've ever got a bit of lung damage. So you need to know that. You need to talk to the pediatricians, look at their chest X-ray, see if they've been on antibiotics, because this is important. And often with the esophageal fistula, it can be the right lung that gets most of the aspiration. But remember, in newborns, the trachea is a little different to adults. So adults, the left one comes off at a steeper angle and the right is almost straight down. In newborns, it's more even. So it's probably 50-50 as to which lung is going to sustain the damage from the recurrent aspiration. And look, babies aspirate saliva all the time, so that's not, I guess, a huge concern. But the bigger concern is if gastric acid is getting into that lung. That's an issue. And if obviously the feeds, we feed the kid and it goes into the lung as well. So the aim is, before we operate on these children, to decrease the secretions and the aspiration risk. So we nurse them in the semi-upright position. We use the Rapogal tube, which is a double lumen, so one lumen suction and the other one sucks in air to prevent it sucking in the esophagus around it. And we can decompress the stomach to improve respiratory parameters. So this was the other thing I was saying we can do to mitigate issues. So if you're really worried about a baby, you can either ask the surgeon or yourself, you can needle the stomach pre-op before you induce them to get any air out, or ideally ask the surgeon to put a gastrostomy tube in. And if the surgeon puts a gastrostomy tube in, that has the advantage that if we're ventilating the kid and we blow up the stomach, we can suck air out of the stomach. When I worked in Ethiopia, I had a very helpful surgeon who did that. When I worked in Michigan, I had very unhelpful pediatric surgeons a couple of times who refused to do it. I think if you have a duodenal atresia, that strengthens your case to put in that gastrostomy tube, because then really that gas has got nowhere to go. But I guess it depends on a few factors. How big the kid is when they're presenting. I'm talking about newborns, obviously, where it's a big issue. And whether or not you can extubate or not at the end, those sort of things. Because one of the other issues with these kids is if the esophagus is stretched, which often it is to make up the deficit because you're missing a little bit of esophagus, so they have to pull it up. If the kid's kept sedated and paralyzed, that's usually means they're less likely to pull out their nasogastric tube and less likely to stick their head back and put strain on the esophagus and esophageal anastomosis. But if the child is going to be extubated, then there is that risk. And so at least if they've got a gastrostomy tube, then they can be fed. So pre-op workup, looking for comorbidities, seeing what their lung is like and seeing if they were preterm and they already have some bronchopulmonary dysplasia from that, or whether it's from recurrent aspirations. And this is what a Rapogal tube, Rapogal tube looks like. So it's got 2 lumens, sits in the esophagus, and you suck with this one, and this one allows a bit of air to come in, and so therefore you can have continuous suction. And this is what a gastrostomy kind of would look like. So you can put medication in there if you need to. You can aspirate it at the start of the case too to improve lung parameters. So it's not a and it's it might leave a small scar, but certainly if you're worried, I think it's worth doing. So the induction technique has changed a bit due to surgical technique, and I think it depends where you do them. So the traditional teaching is inhalational induction and intubation, and then the surgeon does their thing. But more and more now in the tertiary centres, either the paediatric surgeons or the ENT surgeons are doing a rigid bronchoscopy to locate the fistula. They're going to work out where the fistula is and then measure the distance from the fistula to the carina and measure the distance from the fistula to the mouth, and then they're going to intubate for you under vision past the fistula. I'm still not convinced as how useful this is. First of all, it takes all the fun out of it for us because then we don't really do anything. We just put the kid off to sleep and then the surgeons intubate and do the operation, and we're just like there to give anesthetic. It's really boring. But the other reason I'm not sure that this is that helpful really is that you're going to want to put the tube as distal as possible. And what if the fistula is in the carina? Is the surgeon going to intubate the right main bronchus for you? I mean, I'm yet to have someone give me a good reason why we need to do this. The only reason I think it's worth doing is to make sure there's not more than one fistula, and also to get an idea of how big the fistula is, because sometimes in these babies the fistula is so big it's bigger than the esophagus, and it can be difficult for the surgeon to know which is the fistula and which is the esophagus and to not tie off the wrong thing. So that may or may not be helpful. There are some innovative ways. If it's a really proximal fistula, then it's worth doing a rigid bronchoscopy, because what I've seen done is with a very proximal fistula, they did a rigid bronchoscopy. They put a wire through the fistula and then put a tube through, and then that helps the surgeon because then they know when they're dissecting down that they can feel the fistula that has their rubber tube in, and they know that they're basically ligating the right thing. And also with the cervical technique, they actually went in through the neck and went down because it was a proximal fistula, and it allowed them to identify the fistula more easily. So I definitely think there is a role for the bronchoscopy, but if it's a standard type C fistula, which is distal, I'm not convinced how useful this rigid bronchoscopy is, because, and I'll talk about this on the next slide, you want to intubate as distally as possible, and you can only go as far as the carina. Any more than that and you're in the right main bronchus, and that it makes obviously your life more difficult. So bronchoscopy or not, gas them down. So you can do a rigid bronch on gas if you have halothane, or if you have a slick surgeon, you can do it on sevoflurane. I tend to run propofol at this point. Give some atropine to reduce secretions. Like any big case, they are going to be in the chest, so you should have a group and hold, possibly even a cross match. At least one large bore IV, if not two. And large bore IV in these babies is going to be, for me, a 22 gauge cannula. And an arterial line, maybe. I don't think it's essential. Sometimes these kids will have umbilical arterial lines. I don't think it's essential because the blood pressure is going to fluctuate when the surgeon's operating. There's not a lot you can do about that. What I find it useful for is CO2 and ventilation monitoring, because these babies are often very small. They're often under 3 kilograms. Often you're ventilating one lung because the surgeon's in the chest and they're compressing the other lung, and so you lose your capnogram. I've only done about 4 of these cases, and in one of them I didn't have a capnogram because I was in Ethiopia, and in 2 of them I've lost my capnogram. And then at least I can check a gas to tell me that I'm still getting some effective ventilation. So it can be useful for that, but I don't think it's essential. I certainly wouldn't delay the surgery for hours trying to get one. So my technique would be to breathe the kids down, keep them spontaneously breathing. Now this is an important point. You want to try and avoid mask ventilation in these kids because there's the theoretical concern that you can blow up the fistula, blow through the fistula and blow up the stomach. And obviously, if you blow up the stomach, you compress the lungs and make everything more difficult, and you can't get that air out of the stomach like you can in a normal baby. So you want to try and keep them spontaneously breathing at least until the surgeon starts the surgery. If they're not doing a bronchoscopy, I'll give a little bit of fentanyl. And again, it comes down to whether you're extubating them or not. Kids with healthy lungs can be extubated. Kids who already have some lung disease almost certainly going to stay intubated. And in a lot of hospitals, these babies stay intubated anyway for a couple of days. But the issue is more with the fentanyl. If they're doing a bronchoscopy and you give fentanyl, they might stop breathing. And then if they stop breathing, that makes everything a little bit more difficult. So I generally don't give it if they're bronching. But if they're bronching, I'll give a little bit of fentanyl. But you want to, again, small dose because you want to try and maintain spontaneous breathing until the surgery starts. Now, the aim is to intubate distal to the fistula. So what the books say and what I've done a couple of times is intubate the right main bronchus if you're not doing a bronchoscopy. And then you have someone helping you listening to the chest, and then they'll tell you when they only hear breath sounds on the left, and then you pull the tube back until breath sounds return bilaterally, and then you should be as distal as possible but not in the right main bronchus. And the idea of that is that you're as distal as you can be, therefore hopefully you're past the fistula. They also talk about intubating with the bevel facing posteriorly to avoid intubation of the fistula, and then rotating the bevel anteriorly to avoid ventilation of the fistula. So what that means is if you think of an endotracheal tube, and I don't think I have a picture unfortunately, but the bevel is the bit, the sharp bit of the tube, like with the hole, it's beveled with the angle piece. So you want the sharp tip of the tube facing posteriorly initially. You want the whole part facing posteriorly so that you don't intubate the fistula, and then you rotate it so the hole is anterior to avoid ventilating the fistula, because once the fistula is going to always be posterior because the esophagus is behind the trachea. So when you ventilate down that hole, you want to be ventilating anteriorly. This is all like what the books say, theoretical, and I don't know how much it matters, but certainly intubating the fistula would be a bit of a disaster. So as I said, intubate right mainstem and pull back until the breath sounds are bilateral. And the books say you want to maintain spontaneous ventilation for as long as possible. I generally do gently test ventilate just to make sure I can ventilate, because you're usually using an uncuffed tube and you might have a bit of a leak. And you want to also see if you can just give a gentle ventilation and make sure the stomach isn't blowing up. And they say you should maintain spontaneous ventilation until ligation of the fistula. And if you don't have capnography, a precoital stethoscope is essential. So that's what we did have in Ethiopia. We had a precoital stethoscope. So even though I couldn't see capnography and I couldn't see the chest moving because the baby was so small and covered in drapes. I could listen with the precoital stethoscope and make sure you could hear heart rate and air entry. And a couple of things we've talked about. The tube position relative to the fistula is very important. If we're too proximal, theoretically, we can inflate the stomach. So just look here, this is the standard fistula, I guess, with the esophageal pouch. So if you're too proximal, gas is going down here, you inflate the stomach, and that will worsen the ventilation and also increase intrathoracic pressure and reduce the preload, and you may need to decompress the stomach. And if it's too distal, you're just ventilating the right side. And usually, the problem with this is usually it's a right thoracotomy. So the right lung is the one there compressing, and if you're only ventilating the right lung, when they compress the right lung, then you're not ventilating anything. And I see a question from Basil. So Basil, do you want to just clarify your question? You can turn on your microphone. Can't hear you. I don't know if you're trying to say something. I'll just clarify what I was saying and then tell me if you still have a question. So what I was saying is because you don't want to intubate, you don't want your tube to be here, say. If the tip of your tube is here and you're ventilating, you could be blowing air down the fistula into the stomach. And as the stomach gets bigger, it will press up on the diaphragm, push up on the lungs, make ventilation more difficult, particularly if you're trying to maintain spontaneous ventilation. And also theoretically can worsen preload by increasing intrathoracic pressure, blah, blah, blah. So you intubate the right main stem initially, and then you have an assistant listening to the chest. When they tell you they can only hear the right breath sounds, then you start to pull it back and you tell them to put the stethoscope on the left chest. You gradually pull it back, and then as soon as they hear bilateral breath sounds, that's where you leave your tube. So you're not bypassing the left lung, you're just trying to intubate as close to the carina as possible. And the best way to do that is to intubate the right main bronchus and then pull the tube back until the tip of the tube is close to the carina. So the benefit of that is then hopefully you're past the fistula. Like I was saying, if the fistula is at the carina, there's nothing you can do, right? You can't go past the carina because you don't want to just be in the right main stem for the whole operation. And what often happens is you're so close to the carina, when the surgeon pushes on this lung, they essentially move the whole airway and you find your tube does poke into that, and then ventilation is a problem. And I've experienced that. So perhaps that is the one advantage. If they've bronched the patient and they know they've seen the fistula at this level and they've put the tube at this level, that doesn't happen. But when you do it blindly and you're intubating almost to the carina, then when the surgeon moves the lung and retracts the lung, it can move your tube. So the benefit of intubating that way is just to try and keep your tube as distally as possible, but in the trachea, not in the right main bronchus. Does that make sense? Yeah, exactly. It's more beneficial in the lower fistula, but we don't always know where the fistula is. So they may have had some sort of contrast study, but it might only be diagnosed from that chest X-ray at birth, and that doesn't tell you where the fistula is. It just tells you the signs that they've got a fistula. So you may not know whether it's a proximal or a distal fistula. If you know it's proximal, then sure, you don't have to intubate as deeply, but you never know how proximal it is. So I think the one I did that was proximal that I was talking about earlier had I don't know whether they'd had some sort of contrast study or whether they'd done a flexible bronch. I'm not sure. But yeah, the aim is for lower fistula. But if you remember the esophageal atresia with the distal fistula and it's lower, that makes up about 3/4 of these. So if you were a betting person and you were going to bet, you'd bet it's going to be somewhere around here, not up here. Okay, so can't remember why that arrow is there, except to say that that's where you want your tube to end up, just above the corona. So often what happens is when you put these kids in the lateral position and the surgeon makes their incision, as you know, a lot of your respiratory mechanics when you're spontaneously breathing relies on negative intrapleural pressure or intrathoracic pressure to expand the lung. Now, when you cut open the chest, you lose that, and then the child has real trouble spontaneously breathing on that side, and so you almost go to one lung ventilation. So you often at this point need to assist the patient when the surgeon makes usually there's a gastrostomy if it's leaking or if the stomach's blowing up, because that tells me that I might need to ask the surgeon to put a gastrostomy in earlier. Touch wood, the few I've done have been able to support the child and not blow up the fistula. Once in the left lateral position, you need to recheck the tube position. So auscultate, make sure you have bilateral air entry. And again, if these babies are very small, you don't have that much room to move the tube up and down before you're, proximal to the fistula or in the right main stem. And I think that is one of the problems when you do this blind intubation technique. So as I mentioned, the surgeons usually go with a right thoracotomy, and they may retract the upper lung, which can cause desaturation due to shunting or due to moving your tube. And they say you can give muscle relaxant once the fistula is ligated. The few of these I've done, that's what I do, but the reality is I'm usually ventilating as soon as the surgeons open the chest anyway, because the kid can't maintain spontaneously breathing. Once they've fixed the esophagus, they'll ask you to advance the nasogastric tube. So you'll usually need to have a normal feeding tube or available, and you'll advance it, and the surgeon will tell you when to stop. So this just illustrates what they do. So you've got an esophagus with a blood supply attached to the trachea. They ligate the fistula. They then have to bring down this part of the esophagus and bring this up, and that does put some tension on the blood supply, and it can stretch the esophagus. And then they anastomose it, and you have a new esophagus. But you can get obviously scarring at the anastomosis and get some ongoing swallowing problems and esophageal dysmotility from that, as I mentioned. So analgesic options. My standard neonatal technique, if I'm not extubating the child, is just an opioid base. So I give them a nice big dose of fentanyl once I no longer need them to keep breathing spontaneously. I give them a decent dose of fentanyl, anything from 2 to 5 micrograms per kilogram, and leave them intubated. If I can't do that because I'm somewhere where they don't have a NICU, then I can give them small doses of fentanyl, put them on a fentanyl infusion, or I can give them a caudal epidural catheter. So a caudal epidural catheter is essentially a catheter you put in like a caudal, but you feed it up to the epidural space to be a thoracic epidural, basically. Do it with an aseptic technique like you would with an epidural, and leave it there. I've never done it. I've seen one consultant when I was a fellow put a thoracic epidural in a newborn for the tracheoesophageal fistula repair, but the child ended up going to the NICU intubated. So I kind of thought, well, you're not going to get a lot of benefit unless you're aiming for an early extubation, say the next morning. I wouldn't bother doing that. And it depends on your NICU. If your NICU is proactive at extubating, then that might be something you can have a protocol for these babies to do that. But if the NICU, like the one was where I was in Toronto, they kept them intubated usually for 3 or 4 days, then I think there's no point subjecting the child to the risk of an epidural when you're going to be keeping them sedated anyway for the ventilation. So you don't really need to try and do a coiled epidural, and then you can just do a fentanyl infusion, or you can give tramadol. And that the reason I have that there is when I was in Ethiopia, we didn't have enough fentanyl. We did have tramadol, and you can give tramadol 1 milligram per kilogram every 6 hours to these babies. And there's been some studies looking at its use in tracheoe-sophageal fistula. 1 milligram per kilogram, these kids are often only 2.5, 3 kilograms, so it's not a lot of tramadol that you need to give them. The nasogastric tube should be sutured in because if it comes out, the surgeon will kill you, because obviously that keeps their esophagus open, and B, you don't want to go poking a nasogastric tube in through the surgeon's anastomosis. As I mentioned, you can extubate some of these kids if they've got a good chest. If they wake up really vigorously, you can try and extubate in the operating room. But these children are at risk of tracheomalacia, because when there's a fistula, you're going to have a bit of abnormal tracheal rings, and they can get tracheomalacia and need reintubation. They may also need reintubation because if they don't have good analgesia, they've got a thoracotomy, they don't breathe up. Even if they've got a slight bit of lung disease, they can get themselves into trouble. At the end of the case, suction the pharynx, really soft catheter. Don't stick it down too far because you don't want to disturb the anastomosis. The complications: early atelectasis, pneumonia, anastomotic breakdown. So atelectasis, obviously, ventilating these kids. Some of these kids already have some lung disease. Pneumonia, because they've had a thoracotomy and they don't have adequate analgesia. They're a sitter. They're high risk for pneumonia. Anastomotic breakdown, that can occur anywhere from early anastomotic breakdown, which is bad surgical suturing, which is going to be around day 3 to day 10, anastomotic breakdown due to infection or poor vascular supply. So the child I did in Ethiopia got an anastomotic breakdown around day 10. And then later they get esophageal strictures due to narrowing at the fistula site, which they often come back for dilations. There's this thing called TOF cough, tracheoesophageal fistula cough, and whether they get a bit of ongoing aspiration or what it is, I don't think people know exactly, whether it's due to a bit of abnormal trachea, but these kids often have an ongoing cough, particularly in the toddler age group. They can get recurrent respiratory tract infections if they've had pre-existing lung damage when they had the fistula, and they are at high risk of gastroesophageal reflux disease due to abnormal motility and poor reflexes. So I'm just coming back. Basil asked a question. You were asking about thoracic epidural in neonates. I've never done one, and I would be more comfortable doing it with the caudal route. But you can do them, yes. I mean, they do have neonatal epidural kits, which I think are like even smaller than pediatric epidural kits. Pediatric kits are a 5 centimeter needle. I think there are neonatal kits which are like even like a 2.5 centimeter or 3 centimeter needle. So you can do them. But I think given that most neonates, certainly in Australia, we do go to the NICU ventilated and are ventilated for a few days, I don't know that there's a lot of benefit in doing them. And in Michigan, I don't know of any. But like I said, I saw someone in Toronto do one once. I wouldn't say it's common in the places I've worked, but I'm sure there are hospitals that do them more. Any other questions? These are really great cases, by the way. They're a little scary, but once you've got the tube in and you're happy and you know you can ventilate the child, they're really fun, because when the surgeon's deep in the chest pushing on that lung, the kid will desaturate to the 60s or 70s, and you'll be wondering if your tubes come out, and you'll start to sweat. And usually it's just because the tube's gone a bit endobronchial, or they're shunting because the surgeon's squeezing that lung. And often you can poke your head over and look at the chest, and when you ventilate, you can see the lung come up, and that tells you that your tube's in the right place. Yeah, Hafez, you want to show some pictures? That's fine. I'll make your, you can become the presenter. And if anyone has any questions, feel free to ask.
Okay, can everyone hear me? Oh God. I have to, this is gonna be okay. Can you hear me? Somebody say yes or no.
I can hear you.
Anybody?
Can you not hear me?
Okay, good. I turned down my volume. This is the scaphoid abdomen. This is a child with a Post-operatively hernia from Rwanda. And you can see the scaphoid abdomen. What they call scaphoid abdomen. Scaphoid, just so you know, comes from the Greek word scaphos, which means boat, because the abdomen looks like a boat. You know, it's a boat looks like this. You know, and so the abdomen looks like a boat. Anyway, so this is the scaphoid abdomen picture that we were talking about. This is the defect being partially did I? No, I guess not. Scaphos, yeah, scaphoid abdomen. This is the defect. It was a posterior defect on the left side. It was a Bogdalek, but the child had a fully hypoplastic left lung, and it was repaired. It was repaired by a German surgeon named Dr. Friedrich Jan in Rwanda. He lives in Rwanda. But as you can see, the defect is here, and it was a posterior defect because the anterior part of the diaphragm would have been about here. And here's the X-ray. Dr. Derek, of course, showed you a lot of X-rays, but this is the gastric bubble on the X-ray. And the heart, you can see, is displaced to the right, and there was hardly any lung here. Looks like, and this is the defect. Okay, so Derek, you can take over again to finish up this lecture if you wish. I'm through. You can take over again.